sharing. Okay, continue. Let me see. Host disable attendee screen sharing.
Okay.
Yeah.
Let me. I think
You
it's.
can allow me to do that, and then we'll go ahead from there. Okay, let me see now. All right, perfect. There it is. All right, here we go. All right, can everyone see the screen?
Yep.
Can you see it? All right, perfect. So, hi everyone. It's, what is it, 6? It's about 8 for me here in Texas. So we're gonna cover today prosthodontics, exactly what we do in oral oncology and maxillofacial prosthodontics. So we're gonna do a quick overview. My name is Dr. Eugenio Aquino. I'm a former UCLA graduate, class of 2016. So I moved to Texas about 4 years ago. And I did my PROS at Michael DeVecchi VA Medical Center and my maxillofacial oncology fellowship at MD Anderson Cancer Center. There's a few fellowship programs around the states, only maybe 5. UCLA is one of them. You have Mayo, MD Anderson, Sloan Kettering, and Alabama, I think, if not mistaken, and one of the Army part. So today I'm gonna go over exactly what is PROS. And if you have thought about it, maybe this will change your mind, because in dental school, they make it seem that PROS, they only do dentures, and that's pretty much. And it's pretty boring, because it's nothing fun, especially after you have to get so many signatures, okay? I'm gonna do a financial disclosure. I don't have anything, I don't get paid for this. And if we talk about prosthodontics, right? So prosthodontics is, according to the ACP, they say that it's the dental specialty pertaining to the diagnosis, treatment planning, rehabilitation, and maintenance of oral function, comfort, appearance, and health of patients with clinical condition associated with the missing or deficient teeth or maxillofacial tissues by using biocompatible substitutes. And this includes fixed, implant prosthodontics, maxillofacial, and removable. So we go from here. Okay, there it is. So, okay. So here's what you guys know what we do in dental school. Your traditional complete denture, your border molding, and you spend 2 hours or 2 appointments and you still don't get it right. And it's frustrating when you're in clinic, especially as a 3rd year. So, and then plus all the signatures that you have to get. So the big myth in probably third, for the first, as soon as you start dental school is PROS, they only do removable. And that's because prosthodontics at UCLA, they pretty much cover removable cases. That's it. They don't cover fixed cases. They don't cover implant cases. That's pretty much pertain to the implant fellowship or oral surgery or perio. And then of course in PROS, you still do your conventional removable. You process all your cases, and you start learning different type of setup, from your monoplane, lingualized occlusion, semi-anatomical or anatomical. UCLA is pretty good at showing you guys everything, and that's something I realized with other residents, other colleagues, that sometimes their program they only show them how to do monoplane, and that was it. Some of them did 3 arches. So you guys are blessed to be at UCLA, because they really push for it. It's a pain in the neck, but they really push for you guys to do a little bit of everything. And that's a good thing about it. So in PROS, you do the same thing. And then here you go on processing, polishing, doing everything else. And that's pretty much the first, at the minute you start PROS, this is pretty much what they push for you. Removable, a lot of removable. Because this is the foundation for fix. If you want to get to the big, nice cases, this is what you need to understand. So everything else will be easier for you as you keep going, okay? So we do removable as well, conventional or implant assisted. You do your ultracast impressions. So you guys get quite a good experience at UCLA from removable side. And that's and you're gonna be doing the same thing at a PROS program, right? And then slowly you start pushing yourself for the fixed side, right? Where you wanna start, usually they start you for maybe a single restorations, 1 unit, 3 unit bridge, because coming from dental school, sometimes you don't get to do a lot of crowns. depends how many patients you have. Sometimes you just barely get down the minimum requirement because you couldn't get that many patients. Some programs have stated that they do 50 over 60 crowns in dental school. I'm surprised. That's good for them. But in some places, you don't, right? Sometimes you're down with 6 crowns, 10 crowns, or whatever the requirement is. So in pros, they know that. The first thing they tell you in pros is actually, it's forget everything you learn in dental school, okay? And the reason is this: every school has their own philosophy, and that's what they push it. That's what they teach their students. When you come out to another school, they have a different philosophy. At UCLA, for instance, they do a lot of RPIs. The I-bar, in Texas on this side, they don't do it. And when you do it, they kind of laugh about it, right? Because everybody has their own little ways. And that's the thing, you start learning different philosophies about how to do fix and how to do remove. And then you're gonna use what makes sense to you, what works for you, okay? So when you come in, you start doing some simple restorations. You can actually do, in this case, I did a fix with an ERA attachment, and then I did a removal at the end. So you go from waxing. There's gonna be a lot of waxing when you come in. And you go to the whole process from casting and doing everything, layering your porcelain. So there's a lot of lab involved. As you keep going, sometimes you don't want to spend the rest of your time waxing. It gets to a point when you become good at it, you need to start learning different things, okay? So sometimes once you kind of feel comfortable and you know exactly how to wax, how to cast, how to do everything, then slowly you can delegate the lab to do a little bit of your work. I mean, in this case, I did a case for cervic crowns. We did a male castable wax. The lab will do it. You bring it in, you verify it with the patient, and then they'll do a cutback and they'll layer the porcelain, right? And then this is how it looks at the end. At the beginning, you're gonna do a lot of your own cases. You're gonna layer your own porcelain. You're gonna do quite a lot of this. Your director, depends where you go at, they'll let you know when it's time for you to send it to a lab, right? Like I said, you're not there to be a lab technician. You're there to learn and know how to do it, but you're not gonna be doing this. Otherwise, you're gonna spend all your residency just doing lab work, right? Which some of this takes a lot of time. Once you're confident and they know you know how to do it, and sometimes they'll actually give you some competency to make sure you know how to do it, and then they can move you on. So it depends where you end up, right? So you do these cases like this, you do yourself from A to Z. You do lithium disilicate crowns, for instance, and then you do your waxing, you make sure it's good, you cast it, and that's fine. As you move on, maybe in your second year, so your first year is gonna be a lot of simple cases, right? 3-unit bridge, 6-unit crowns, some aesthetic cases, maybe do a lot of surgery, maybe like extractions, stage 2 surgery, bone grafting, little things like that in the surgical side. As you go on, you're gonna slowly learn how to do your comprehensive cases, your full mouth rehabilitation cases, okay? And I'll say full mouth rehabilitation. I don't like to call it full mouth reconstruction, right? First, you need to rehabilitate the patient. So once you start going in your second year and now they're pushing you for bigger cases, more complex cases, you need to know how to rehabilitate your patients, which means how to stabilize them. A lot of patients where I was, they were clenchers. And I'll show you a picture of how big of an exostosis will look on some of these patients. So you learn how to stabilize this patient. And then once they're stabilized, right, then you start. And also a lot of times you will test drive them, meaning that you can give them an occlusal orthotic appliance at the vertical that you're trying to restore this patient. And you see how they're gonna react. Now, this is what's gonna make you different from a general dentist, right? Now, there's some really good general dentists. I'm not gonna try to say there's some really good general dentists. But you as a prosthodontics, you're gonna learn how to select patients. For instance, if I know during the assessment, during all this test driving, before I even touch a tooth or prep any of the teeth, if the patient cannot tolerate what I'm doing, when I'm trying to stabilize this patient, I'm not gonna prep one single tooth on this patient. So this is what makes you different, because you're gonna learn as a prosthodontist which patient you should treat, which one you should not treat, okay? So this is how you're gonna get yourself out of trouble. So you're gonna learn. Sometimes you just have to say no to the patient. And And they might go down the street, somebody else say yes, and then they're married to that patient, okay? So once you stabilize the patient, you start doing these cases. Now I put this case because there's different ways to skin a cat. That's what they say. There's different ways to do to carry a full mouth rehabilitation. You can do them in sequence. That's what I did here. I did the posterior crowns first, and then the anterior, and it's less stress. You don't feel you're doing a full mouth reconstruction, a rehabilitation. Sorry, when you do it in sequence, right? A lot of time you're supposed to do the anterior first, but in my case, when I decide what kind of occlusal scheme I'm gonna give the patient, I do it on my provisional stage, right? Because when you do your wax, your wax, you actually kind of, you might put them in a mutually protective occlusion, but you don't know if the patient, that's what the patient can tolerate. You will know that when you give the patient a prototype or provisional, and then you'll decide. And from there, you can make a customized inside the guide table, and you have all these little tools that you can give to the lab. Okay, so you can do this at the end. You try to do all your lab work and have your occlusion. Okay, so in some of the cases, you want to get as many contact, right? You don't want to have a full mouth rehabilitation. You get a little point here and there. You're trying, occlusion is a big thing once you do these big cases. It's a little blur on this side. This is what I was telling you, right? When you deal with patients like this. So this is a severe clencher, right? And this has been going on for years. Now, if you look at this big exostosis, right? If you do not stabilize this patient, he's gonna destroy pretty much anything you put in his mouth, okay? And this is when you come in, right? You stabilize the patient, and you will understand how to stabilize the patient. And as you keep going, once the patient is stabilized with an occlusal orthotic appliance, based on the vertical that you do your diagnostic wax up, because you have to do your diagnostic wax up first, and do an aesthetic mark if the patient is willing as well to do it. So in this case, patient came with a lot of erosion. Patient already started taking medication. There was a lot of composite patch here and there. And then we're trying to rehabilitate this patient completely. You do your diagnostic wax up. That's the first thing you do. And from here, you're gonna do your aesthetic mock-up, okay? As a prosthodontist, I'm not gonna touch one single tooth until I do my aesthetic mock-up. I bring the patient in, I can get a potty, try it, see how they like it, see how their aesthetics, phonetics. Because if they started giving me problem at this point, then there's no reason for me to continue. And a lot of times you gotta tell the patient that this might take half a day sometimes. It might be an all-day procedure. And if they're not willing to stay with you, then there's no reason for you to proceed. Because it's gonna be a nightmare once you're there, and you just can't move on with their cases. So you learn how to do your prototypes. Sometimes you can do a full arch as a prosthodontist, right? For me, I usually use back-to-back double cord technique. You will learn how to do this. It's more stressing than when you do it in sequence. Because if you don't know how to play with your PVS, your extra light body PVS, by the time you're done pouring all the margin, it's already set. So there's a few tricks that as you go on, and I think I post some of it in Dental Clinical Pearl, how to take a full march impressions. And then you do get cases like this, okay? So sometimes in dental school, you're having a hard time taking 1 or 2 impressions, right? As a prosthodontist, you learn how to manage big cases, complex cases. You know how to go from A to Z. You know where to stop, where not to see a patient, right? And then same thing for the mandible, right? You find different ways, and you start taking full arch impressions. This is what prosthodontists do. We don't do a lot of dentures. And you'd be surprised that I only do dentures when I do a fixed case. I barely do a lot, just dentures, just removable dentures, right? On maxillofacial, you do, but as a prosthodontist, you don't do as much. As a general dentist, you tend to do more. So just keep that in mind, okay? And then your prep, right? You learn how to respect the tissue, you learn how to prep properly. And this is what prosthodontics do, right? Complex rehabilitation cases. And as you go on, you will get your speed, and you will learn how to prep and how to restore your teeth. In any PROS program, right? I believe, hope I'm not wrong, but they make you do all your lab work, right? Nothing is sent to the lab. Maybe your final year, they might do it, but some places, they make you do all your dies, all your solid models, right? And it's better, I think, because you know how to, you mount it, you have control of everything. A lot of times the lab technician might not know, and then your mounting is off. So when you try to deliver the crowns, it's all over the place, okay? So as a prosthodontist, as a resident, right, you might not do this in private practice, but at least you can teach your lab how to do it properly because you already have the experience. So you do your mounting, you do your dye, you do your solid models, and you check your occlusion, everything before the patient. So when the patient comes in and you know the path of insertion, which crown should go first, you should be just dropping. You should just put the crowns, check occlusion, it should be it. You should be making very minor adjustment. That's it. In dental school, it's not like that because you get a crown from the lab and you spend so much time removing interproximal, right? Or sometimes you end up removing the whole anatomy of the crown, right? When you use triple trays or things like that. In pros, you're supposed to keep everything prestige, the anatomy, the occlusion, right? This is what you're gonna get in a pros program, okay? And the crowns. These are actually zirconia crowns with facial layer cutback, okay? So the lab pretty much just gets the case and then they just scan it and that's all they do for you. In some cases, you start to do like hybrid cases, right? Or some fixed dental implant-supported fixed dental prosthetic cases. So the following is actually one with, you might get a patient like this. And sometimes, right, patients that pay for their implants, right, sometimes they're not willing to remove that implant. So this is a cool case. Patient came in a dentulous. He paid $2,000 for this implant. For 2 implants, one failed, this stayed. He was not willing to remove this, right? Even though we're gonna do a full mouth reconstruction, he was not willing to remove that because he paid $2,000 for that little sucker. So he wanted to continue with that, so which is fine. We did that. A lot of times when you do complex cases, right? When you start doing removable, patient, their hygiene is terrible sometimes. So for us as a prosthodontist, you don't start anything fixed or implant unless they work on their hygiene. So that's something you have to push as you start working your cases. Once they work with that, you can move on. Now, why am I doing a denture for a patient that I'm gonna do a fixed case? And this is what I said last time. Your removable is the foundation for your fix. You know, if you know exactly how it's supposed to look at, you know exactly how the final prosthesis is gonna look. Okay, but for that denture, I use that denture and use CAD/CAM technology to fabricate a fully guided surgical guide, and I use a dual scan. The same denture, you scan it, you go on the software, and you start playing with this, and you create your own surgical guides, right? Where you know the drill, you know everything about this, and that's what is gonna make you different. You just don't send it to the lab. Before it used to be like that. Now you do it yourself, and this is as a prosthodontic, this is what you do, right? You know exactly where the implant should go, how it should look like when you do the surgery, okay? This is fixation screws that you kind of fixate on the patients, and these are the implants. One of these implants, right here, right? Patient refused to get the remove, and you can see the implant here. It's supposed to be more palatal, so we kept it in there. And there's threads already showing, but hey, that's what the patient wanted, so we couldn't find one with this guy.
And you placed all these implants yourself?
So some of them I played myself. Some of them, this is one of my first cases that I started doing. The oral surgeon was next to me helping me out. Okay. So as you go on, it becomes easy. I think for implant, it's not so much the placement, right? I think the planning. Once you have this guide, everything's easy, right? And then the only thing is like how to flap, things like that becomes easy. So this is one of my first cases that I started doing, right? Usually they start you in a simple case, and as you feel more comfortable, they'll jump you into the big cases. And once you know how to do that, you can go on. So it's not that hard. So this is one of my first cases. I did half, he did the other half. And that's how you move on, right? And this is how the implant look at the end. This right here, this is a big problem, right? Because there's gonna be a problem when I restore this. But we couldn't force the patient. We try, and it gets to a point where you just let it go. You're like, that's fine. Things are healthy. And then you do your normal, right? You do your verification jigs to carry out this process, right? And you'll be doing a lot of this as you go in process. And then you have your final prosthesis at the end, right? And you had to use a custom abutment on that implant that was too facial for this case. The mandible, we have to restore, right? Patient just wanted to get the maxilla done, but the mandible, the occlusal, it was terrible. So I had to restore the whole thing. And sometimes you have to let the patient, right? It's gonna take time. You can't just start doing things on the maxilla without making sure you have a good occlusal at the end. So I end up, talking to the patient. We end up doing all restoring upper and lower. So now, many times when you do this, right, like I say, your denture, the same denture, you can actually convert that into an interim hybrid. That interim hybrid, you make a duplicate, you send it to the lab. So this is what the lab is going to use when they actually create a prototype, right? This is the prototype I got for the patient, right? I like how everything looks. And then once you're satisfied with this, right, then they'll make a final prosthesis on zirconia. These are zirconia with facial layer cutback on the definitive prosthesis, okay? But it looks pretty good because like once you have the prototype, I usually have the patient wear it for 3 to 4 weeks. When they come back, I remove it. I give them the interim hybrid, which is their denture that I converted. And I take the prototype and I send this to the lab. Sometimes I'll remount it. I'll take a bite, I'll remount it. And the lab will scan this again to give me an occlusal that is ideal as possible. Now, does that mean digital is perfect? No. There's always discrepancy. So you have to make minor adjustments, but it's not going to be gross adjustments once you get this at the end. So it should be pretty quick when you deliver this. And then you always give them an iGuard at the end, okay? When you have your iGuard, make sure you get even contacts, right? The occlusion on an iGuard and occlusal or orthotic appliance for TMD is very different, right? So you just have to know what exactly you're doing. But in this case, an iGuard, this is make sure the patient has even contact, things like that, and they'll be fine. You got to protect those. You have to protect your work for every full mouth rehabilitation case. Next case, actually another case. There's an interesting case because like you do cases where patients, this patient got edentulous at age 24. Nobody knows he had dentures, right? In his family. So we did this case. It was like a 9-day difference. At the same denture that I got from him, I did a dual scan, we did a surgical guide, and then you carry the same prosthesis. And when you make your verification jigs, you can use Duralay or try different things. You try things as you go on, right? Same thing. This is what I was telling you, right? You get the patient's denture and you convert that denture into an interim hybrid. This is what the lab is going to use to give you a prototype based on what the patient you have. So that's why the denture has to be so precise. And that's why you still have to, I do the dentures only for me to restore the big case. So it can be simple for me when I get to this point. If you know how to do it this way, your full mouth rehabilitation cases becomes very simple for you. So you don't have to be, guessing and things like that. It's just like, you just carry it from A to Z with no stress, okay? And sometimes you might get another prototype just to make sure. This one, I just did it just because I wanted to try. And I got this prototype just to see, right? If I have to make any adjustments, this is white resin. And then if everything looked good, and then I created a prototype for this case. So I give them this for 3 to 4 weeks and bring them back. This is the final, yes.
So did you make an impression of the actual denture to make the prototype?
Yes,
right
so absolutely. So that's a very good question, right? Because how do you convert and how do you communicate with the lab? So when you have your upper and lower denture and you convert, now you see that little thing right there at the bioregistration? Before you convert, before you pick up, right? Before you convert them, once the patient has a denture, take a bite, okay? So when you pick them up, you can use this bite as a reference. Otherwise, occlusal might change. And I've learned the hard way, okay? Once you have this and you pick them up, both of them, then you can remove the dentures and you cut them. And then once you have your upper and lower as ideal as you want, you make an impression of that, okay? And then you cross mount, okay? Once I have the final, the interim prosthesis on his mouth, and I have my master cast already, I'm gonna remove that interim from his mouth, okay? So first I take an impression of the upper and lower. That's the first thing I do. Then once I take the impressions, I pour it, and then I remove that interim hybrid, the one I just converted. I take it to the lab, I mount it, right? I put this interim hybrid to the master cast, and I mount it. Once I have them mounted, I cross mount the impressions, okay? And then that way my mounting is the same at the end, because this is what the lab is gonna use. So when they stitch this together, it's gonna be as ideal. Maybe one of these days we'll do how to do this step by step, right? But this is pretty cool, because when you have this, literally the lab, it makes it so easy for the lab. Because like you're just trying to replicate exactly what you have, and it'll make it easy. Did I answer your question?
Yes, you did. Thank you.
Okay. And this is the final. Sometimes you might have to make modifications to give the patient, and then these are zirconia with facial layer cutback at the end. And I'm sorry, a lot of times I don't put the patient's picture, because a lot of them, they're from the federal hospital, and some of them are from MD Anderson. So there's a lot of rules. We can't post pictures unless for conference, and we have to get the permission. So I apologize for that right now. So this is one, their face you're never gonna see. So this is how the patient look at the end. Something with patient, when you do full rehabilitations, their smile. Some of these patients have not smiled for 20 years, 15 years. So you can't get this idea where, when you do your aesthetics, when you kind of, the upper follows the lower lip, and some patients have asymmetrical smiles. Some, you can't just get it the way you want. So you do your best, okay? Sometimes in a process, you learn how to deal with implants in the aesthetic zone, right? And this is a case that it looked pretty good, but the lab mess at the end, I'll show you why. So patient shows up like, a lot of time patient will show up like this, and how do you maintain that architecture, right? So for this case, you do your surgery, you actually print your surgical guide, I made some customized ceiling abutment for this case, and then then the surgery was done, right? Once you have the guide, it's so simple to do your surgery, honestly. You still need to know how to freehand. But once you have a guide, man, it's just like, my first implant took me less than 5 minutes. And literally like 2-3 minutes I was done. I was like, okay, that's pretty cool. That's so easy. So the guide makes it easy, but you need to know how to freehand. So I did this. I give them some customized ceiling abutment. I give them an S6, right? Sometimes I don't like to do immediate loading. I very rarely do. But sometimes I just like, I'll try different ways. But in this case, I give them an S6 with the customized ceiling abutment. Patient came back about 3 months, and then I made him provisionals. So this is a provisional for this patient, okay? I have the whole architecture, my gingival zenith. There might be a slight discrepancy here, but it was pretty good. And make sure there is no contact on occlusion and on your eccentric movement. So no movements on lateral intrusive, medial intrusive, protrusive at all, okay? So they don't break this. This is how the patient look at the end, right? You start sculpturing, you learn how to start sculpting your tissue. So once you get the provisional, and you see this, right? You have an thick, keratinized tissue. The tissue looks healthy. You're gonna get your crown, your provisional crown, to make some customized impression copings, okay? And from here, once you pour it, this is what you get. And this is what you send to the lab. So you do a tissue moulage, and you tell them, this is how my architecture looks, right? And you wanna replicate that at the end. Now, you're doing everything correct. Sometimes the lab might mess up your case, and here's the case why, right? At the end, you know what the lab did? They actually did not follow all the tissue moulage. They made it a little bit shorter, a number 8, okay? If you look at the provisional on the left side, and you look at the final restoration on the right side, it's not the same. So when you're a pros, show your good cases and bad cases. Okay, it's okay. This is a learning curve, right? You make mistakes, and that's how you learn. In this case, I was mad because I gave the lab everything they needed. I sent pictures, I did the tissue molars, I mounted. They just had to replicate what I had, and it was not done. Now, I think it's good, always ask, even as, if you go in a general dentistry, always ask for updates with your lab. Tell them how things going, send you pictures. You tell them you want to see the case before they proceed. So you don't have these kind of cases at the end, especially for implant, because you might charge a lot and then patient might not be happy at the end. This patient had a low smile line, which was good for me. He didn't care, right? I think we care more as dentists, right? As prosthodontists, sometimes you're more anal about things. I was gonna get this redone, and I was gonna get this cleaned, the interproximal between the lateral incisors. He was going out of town, so he just needed to go, right? But he was happy. I could not. You couldn't see it, right? But if it had a high smile line, then it could be a problem, right? Aesthetically. So these are the type of cases you do. Surgery cases, yes. Like you're gonna learn how to do your tooth supported, mucosa supported, bone supported surgical guides, and then you'll care. And when you do this, you force yourself to plan the case. You know exactly where it's gonna be at. You learn to determine where it's gonna be the smile line. So when the patient smiles, you don't see the junction, right, between your prosthesis and the mucosa, and that happens a lot of time. They think, this is so easy, right? You start placing implants, and then when the patient smiles, like, oh, patient had a high smile line. So you need to know exactly where the smile line, how much bone you have to reduce, where the implant has to go. So it forces you to think and plan cases when you do your surgery cases. As a prosthodontist, you're gonna do a lot of your surgery cases, okay? You're gonna be placing your implant. Sometimes, even me, I think when some cases, I'm not gonna do a refer out. So you should know your limitations. Even though you do a lot of surgery cases, there's cases where the periodontist has to place the implant. There are cases where the oral surgeon has to do the case. So don't get in trouble, right? Do what you feel comfortable doing, and anything you're not, just refer. That's it, right? You always need to have a group of doctors that you refer with, and then do cases that you feel comfortable doing. Sometimes you do cases on the maxilla. So once it's guided, it makes it easy. A lot of people do free-handed, right? I'm not at that level yet. So some people can actually go ahead and do freehand and everything. That's fine. If it works for them, amazing. For me, I like to see I like to be very predictable, right? How things are gonna look at the end, where my axis is gonna come like. I don't wanna be guessing, right? Or maybe I'm not at their level yet, so I can't be doing things. So I depend a lot on a guide, because it makes it easy for me to restore. I don't have to be, trying to make custom this. Like I just know exactly what to do, and it's just easy for me. Once you plan these cases, it usually takes some time. So you might spend hours, even days, when you learn how to use the software. But as you go on, once you're pretty quick, you can plan this case in less than 15 minutes, and then you print it. It makes it easy, right? So it's a learning curve, but it's quick. So something that you use a lot, you guys are free to use whatever you want. Blue Sky Plan, it's a free software. It's pretty good software. They only charge you to transfer your STL files. We used to have Simplan, but they charge a lot of money to do dual scans. You need money for everything. So that's something you want to, where you end up, they might have a different software. Just use what they have, right? And try it, see how accurate they are. Because even though it's guided, sometimes there's still inaccuracies in these guides. Okay, so make sure you know that as well. But you'll be doing all of this in a PROS program. You create your guide, you do everything from A to Z, okay? You do many other implants, 1 implant, 2 implants in the posterior. Like you start doing this, once you know how to do a big case, everything else becomes simple. Once you know how to do things on the aesthetic, right? And you need to know how, the aesthetic is a very more detail. So you really need to know, and review all your literature before you start jumping into aesthetic cases. Sometimes you get cases that you don't know what's going on, right? This case, it's a huge anterior maxilla. I mean, super erupted, extruded anteriors. How do you restore this kind of cases? The patient had an RPD that it just pushes lips so much forward. So you learn how to do those cases. Cases when you're what's going on here, right? You might think this guy has so much bone until you take a cone beam and it's like paper thin. Exactly what happened in this case. With that, we're gonna do an immediate loading, perfect, right? We take the cone beam and there's no bone. whatsoever. It's like three. Um, can be crazy. Now, in some pros programs, you might do what you call is maxillofacial cases. So some programs, they do that. They'll throw in, or if they don't have the patient, sometimes they'll do an exercise for you to do them. I was lucky in my program. We had a maxillofacial patient. We had 2 maxillofacial prosthodontics working there. So they'll give me cases, right? This is a cool case I did with Dr. Wu, one of my prosthodontists at the VA. We actually scanned the patient's face and we duplicated, and we actually flip his good ear. And then we did so we took an impression and then we did everything digital. Because when you make ears, it's so easy to, when you wax it, you don't know what angle it is and what position. So this helped us pretty much. And it was good because when we tried it, was just like dead on, right? We had to make a little wash at the end. We actually ended up making shells to inject your silicone instead of doing your traditional waxing and, you know, pouring and duplicating all that part. We did a little shell, we injected the silicone, and we did external staining. So you do cases like this in a PROS program. This is another ear case with implants, regular implants. You learn how to do those cases as well. And then you do some obturators, right? Some of my co-fellows, they did 3, 4, 5 of them. I did only 3, but it varies from programs. So sometimes you might learn how to they might teach you how to do this in your PROS program, right? You learn how to do a sleep apnea appliance. That's pretty easy to do. I mean, the lab does it for you, and it's very simple, but you learn how to do that. And MD have to give you an okay for you to do that. And TMD patients, right? Occlusal orthotic appliance. Something I'm very happy in my program was actually we covered TMD for 3 years. So we used to have a chronic TMD specialist come to teach us once a month and see patients. So we see our own patients, and any complex patient, we'll see them once a month when he comes in. So a lot of programs will teach you how to deal with TMD patients. So you do those cases as well. So that is PROS, right? It's not about just dentures. You do surgery, you do complex rehabilitation cases, you do aesthetic cases, you do veneers, you do everything. But the difference is you really understand when to say no. That's PROS, right? When to say no. Now, as you can see, I don't do a lot of dentures. That's like, as a prosthodontist, you don't do that. You do them only for fixed cases or maybe just for some, but most of your job is going to be surgery, full reconstruction cases. So it's not just dentures all day. Some people like to do them, but it's whatever you like, okay? And then there's another fellowship, which is oral oncology and maxillofacial prosthodontics. That's an extra year fellowship if you want to do it. I think you should do it for me, I just feel like you're more prepared. And I think it opens door to many places. That's what I've noticed, right? There's only right now, I think maybe 10, 11 spots in the United States. There is a lot of hospitals that they don't have maxillofacial prosthodontics, right? And this is a good resource because when you're a maxillofacial, you just don't depend on your general dentist, which a lot of times your general dentist will do a lot of the big cases, right? So you'll see that it's very, you might not get a lot of referrals from your general dentist, okay? A lot of time you get your referral from your own specialist. That's what you need to work with your perio, your ortho, all this, everybody. In maxillofacial, you can get a lot of referrals from plastic surgeons and head and neck surgeons. See, it opens you another route, right, for cases. And that's the beauty about it. And not only that, so my case, I did my fellowship at MD Anderson Cancer Center, and we primarily deal with cancer. Some programs, like probably Mayo and some other ones, maybe Sloan Kettering, they might do some trauma cases, maybe congenital defect cases, and that's fine, right? But MD Anderson's primarily on cancer, and that's what I did for this case. So why do maxillofacial? Well, you learn how to deal with cancer patients. Once you have the philosophy, pretty similar for trauma patients, congenital defect patients, complex rehabilitations, medically compromised patients, right? You learn how to do a lot of surgeries, and you learn how to work in a multidisciplinary team. So you learn how to work with head and neck surgery, plastic surgery, medical oncology, radiation oncology, oral pathology, and then your anaplastology, okay? Now, when you get to this one, you learn how to deal with radiation patient, and that's what I said, right? So a lot of time when patient go to radiation, there's a lot of side effects, right? And this is something, even as prosthodontics, you guys covered this, but you covered this more detail in a maxillofacial process, because you know how to read the symmetry of the patient, right? You know exactly where it's safe to do surgery, where it's not safe to do surgery, and you need to know the side effects, right? Before the patient goes radiation, what do you do as a prosthodontist? What's your prevention to prevent complication in these patients? And a lot of times you're gonna see this patient during radiation, right? So during radiation, the first three things that the patient have a lot is actually oral mucositis, xerostomia, and lack of taste, guzia. That's what you see right away. And you need to learn how to deal with that, just in case they send the patient back to you. A lot of time, radiation oncology will deal with that. They might give them some lidocaine rinse, or maybe you try to give them something for their xerostomia, things like that. And after, that's another thing, right? You need to learn how to deal with these patients once they're done with radiation therapy, right? Because a lot of times their xerostomia might be permanent, right? So salivary glands are very sensitive. After 26 grades of radiation, they'll permanently shut down. That means around 3 weeks if they're getting 2 fractions per day, right? Their oral mucositis usually goes away, right? And their taste usually comes back, okay? Trismus is another thing. A lot of times they might develop trismus during radiation therapy, right? Because a lot of you do as a maxillofacial, a lot of times your radiation oncologist will ask you to do a radiation stent. Sometimes they use a little fork, so they don't request that, right? It depends on the cases. Sometimes they cannot use the radiation stent, and then you have to deal with that. So you have to know how to manage the trismus. And a lot of times, once they're done with radiation, they might develop trismus 2 years after, right? So that's so you need to really know how to educate these patients. Ulcerative necrosis, that's another thing, right? There are a lot of patients will forget, and a lot of dentists will get in trouble for this because maybe they didn't read the medical history, or they didn't ask, things like that. But patients, they're in a risk to develop ulcerative necrosis. Sometimes even if they take care of themselves, they might still develop. So usually you have them see their dentist 3 to 4 months after radiation, and then slowly you can proceed to 6 months as you go on. So you learn how to deal with radiation patients. You learn how to deal with patients undergoing chemotherapy, stem cell transplant, bone targeted therapy, leukemia, or metastasized cancer. So you really get an idea how to deal with the most complex patients, right? Besides what Pros gave you. So this is what makes you unique, because anybody that comes in, you're not gonna be scared to see, right? You learn how to do obturators, right? So usually on obturators, you do a surgical, an immediate, and a definitive obturators, right? And then this is just a picture I got from an article. You see the defect. When patients don't have this, they have speech problems and they have nasal regurgitation. So they're eating and the whole liquid comes through their nose. So it's very sad for them. And a lot of times they don't get an ALT flap to close it, so they depend on a obturator. So you learn how to use that. You learn how to do mandibular resection prosthesis, right? So if the patient gets marginal mandibulectomy, segmental mandibulectomy, total mandibulectomy, you learn how to restore the patient, right? Those are the things that you get. And I'll see if they get like microvascular fibular flip flaps. That's another thing. You learn how to deal with their speech. So some patients, they might get partial glossectomy, right? This is a palatal augmentation prosthesis. So sometimes when their tongue does not reach their palate to make the sound, you can make an augmentation prosthesis so their tongue can touch and they can speak, and it can help them with their eating. So those are the little things that you can do, and this is the reason. So for this, you usually use this augmentation prosthesis when patient has partial glossectomy, when they remove 20, 50, or 75% of their tongue, when they get the floor of the mouth resected, when they get mandibulectomy, or they have hypoglossal nerve paralysis. That's when you use this. And this is a cool case because usually a lot of the palatal augmented prosthesis, it's done the conventional way, acrylic. I did this one using digital, right, to duplicate it. So I'm gonna publish this soon. I'm gonna publish this case soon because I use I printed this with the little hollow inside, so it's very light. So it's gonna be actually it's better for the patient because it's not too heavy. So this is pretty cool. So I'll let you guys know, but that's something we're working on to publish. And then of course, and this will happen with the speech under swallowing. So you learn. So this is I think this is one of the big cases too. When I said the team, when I told you that you need to learn how to work with head and neck surgery and plastic surgery, this is the cases. So when you do microvascular fibula free flap, when they remove their face, half the maxilla or the mandible, they're gonna get bone from their leg, the fibula. So you plan it with them. So you tell them exactly where you want the implant to be placed, how are you gonna do it. Sometimes they do jaw in a day. So in New York, they do it. So the patient goes in, they remove half their jaw. They remove the whole, half the maxilla, the mandible, or they do total segmental mandibulectomy, and they give them a prosthesis at the end. So when they come out, if they remove the whole mandible, they can come out with a microvascular fibula free flap with the prosthesis at the end. So you cannot tell what the patient had, right? So that's things you do. So you learn how to work with them. Sometimes you have to go to the OR to do the implant part. Unless the hospital hire an oral surgeon to do the implants, then that's okay. If not, then you have to go and place the implant yourself. You have to go and cover those implants. You have to go and debulk the fibula flap. So that's what you do as a maxillofacial, right? Of course, and everything you do in a dental clinic, your biopsies, your cultures, that's something everyone does. You do your surgical extractions and then implants on native bone and fibula, right? So the fibula is something that maxillofacial pretty much works with, right? And that's something cool that you do in maxillofacial process. I'm sorry, as an oral oncologist. Now, extraoral prosthesis, you work a lot with your anaplastologist for this, right? Or sometimes you might just do it yourself. It's whatever you feel like you want to do. But these are some cases that I did. You learn how to make an eye, you know how to stain it, how to do the waxing, how to process in silicone, and how to do external staining. I don't have my external stain pictures, but you learn how to do that as well. You learn how to do your ears, right? A lot of times you're not gonna be doing, I think most of the time anaplastology will do this for you, but you're gonna guide them and they might come to your office or you might send them out. But otherwise, in some program, they do everything, or if you work some location, you just do it yourself, right? That's something, depends where you work at the end. And you make noses as well. So that's what you do at the end. So as you can see, pros, it's not just about dentures, okay? It's about everything. So you come out knowing like so many things, right? And that's something a lot of dental school, they don't teach their students, right? We come up with the idea and the myth that pros only does dentures, and it's not. You do them as a foundation for your big complex rehabilitation cases because it makes your life very simple, right? So that's what we do. This is what maxillofacial does in oral oncology. It's like this, you play with so you don't rely just on general dentists, you rely on plastics and head and neck surgeons to see a lot of your patients. So you can see a lot of their patients. So it's you just open your way to so many. You can do maxillofacial, do it. I'm telling you, 1 year goes very quickly. And if you try to finish and go back, it's hard to do it, But if you can, try it. If you like it, try it. But I feel like it just opens your way to so many doors at the end. Questions?
I have a question.
Yes.
So you were mentioning how important it is for to select your patients. Sometimes you have to say no to certain patients because of maybe their cases. So what would you do in those cases of those patients that, for example, that you cannot treat them?
So when I say let's say, right, I assess the patient and then I give them an occlusal orthotic, right, based on what I think, based on the height that I want to restore this patient. I give them this appliance at the vertical I'm looking for. This is how I'm test driving this patient, and he cannot tolerate it, right? Or his jaw hurts, and I cannot stabilize this patient. Then it's not, because he might have TMD problems. So if I don't stabilize that, I'm not gonna tell you. Even these guys here's $40,000, $80,000, do it for me. I'm not, because I know I'm making more damage than good, right? And a lot of times patients, they go out with some other doctor and they'll say, yes, they see the money. You're like, oh yeah, I'll do it, right? But once you have this patient in your office every day, or they're calling you because their jaw hurts because what you did, then that's, you're married to this patient, right? So you learn how to assess and how to test drive and how to manage them. Or sometimes their attitude, right? If they're not willing to sit there for 2 hours, an hour, and they just want to move quickly, why are you going to do that? Just, you know what, you're not a candidate for this. Because I tell them straight out, if you cannot be here for half a day, or sometimes if I want to move your case, more than half a day, then there's just no. Or or when I do an aesthetic mock-up and they're not happy, or their speech, or usually everything goes good, but let's say something's not happy, then they start making excuses, and they're just like, we deal with the very challenging cases, right? And we learn how to manage them. But there's some cases you're just like, you know what, this is not gonna work, right? So you learn how to do, and usually you do. You become pretty good how to manage them, regardless how complex they are, regardless how complex their medical issue is. But it gets to a point where you just have to decide, right? Maybe I'm not the right doctor for you, right? And even when you actually treat chronic TMD patients, right? So when you acute and chronic TMD, it's very different, right? Acute, anybody can, you make an appliance, they're fine, right? Anybody can do a little closed orthotic appliance. But sometimes when they come back with you with a bag of appliance, a bag of plastics, that means either they didn't know how to work with the occlusion, because that's a big thing, right? And it depends, like this one depends who you listen to, but there's a lot of, for me, I'll probably believe more someone that does chronic TMD. That's all they do for a living. There's only one guy here in Texas, maybe two, that does that. So if I see that, I'm seeing that, you're bringing so many appliances. So maybe it's not something biomechanical, maybe something medical, maybe it's just psychological, right? So regardless what you give the patient, it's more in their head. So sometimes you have to be a little psychologist, and that's how they feel good, and that's how they feel better, right? But little cases like that, so that's how you manage them. That's how you kind of prevent, like, I'll probably not do this, So is this something that you guys think Pros does, your CLA?
I have a question.
Yes.
What would, since you're a UCLA graduate, if you could go back, what do you think you might do differently as a dental student?
To learn, or or what I expect the faculty should do?
I guess to get through clinic really well.
Okay, so I think to get through clinic, I think the problem is, like, as a dental student, you just go through so many signatures. Everything's like every step you take, they just overlook at you, right? I think sometimes it's hard to move on, or you might be in perio jail, where if the perio is not done, then you just can't move on with the patient. Okay. I think for me, the biggest when I was at UCLA was the perio, right? If sometimes they're so busy or they can't see my patient, something minor, they just like, I can't do anything. I think that selecting the patients, it's going to be the best. If you can bring your own patient, that's going to be better. Sometimes it's good to bring a lot of your, are they still doing the complex, what is it called? When you present your case, they're going to have perio, pros, what is it called? No, what is it?
Complex treatment planning.
Complex, yeah, I think it was like ATP something, right?
ATP, yeah.
Yeah, ATP, that one. Advanced treatment plan, yes. I think you can bring a lot of those patients. I think when you bring a lot of the ATP patients, it becomes a problem, because it's hard for you to move them. Okay, if you can find patients that are a little more simple, young patient that they need a crown to crown, then you can get a lot of your requirements done. Okay, prepping. I think something I would have done, and I think right now maybe I didn't have. I don't think we had that luxury, right? How to prep. When you go to clinic, sometimes you're like, oh my God, what burr should I use? How to prep, because you forget everything you learn in lab, right? What burr, how many size should I do? 1.52. You're like, okay, and then you get confused, right? And the patient is there, you're trying to know the patient, everything becomes a mess, right? I think if I had Dr. Stevenson's, I'm sure you guys know who Dr. Stevenson is, his YouTube videos, I would have been so happy because I can just go overnight, sit down, look at the video, and just like, boom, you know. That would have been great for me because like, it's for me, sometimes I'll be there and then you blank. And then a faculty comes in and asks you a question and then you blank again, right? It just happens, right? You just like you're like, uh-oh, like, or they ask you, what are you going to do today? And then you try to remember, and then you mix your focal crown with your PFM or your latent aesthetic crown, your Emax, and you're like, okay, you get all the numbers mixed. But I think the video will help. And then just write down what you need and the burrs. But I think patient selection is going to be the best in dental school. I wish I did a lot of ATP cases and some of them moved, but I think that was my problem. I did a lot of it. I wish I would have done more simple cases. To move on, yes.
Is private practice, and how common is private practice for maxillofacial prosthodontists?
Okay, so once you're done, before you're done maxillofacial, you gotta get a lot of offers. People are gonna start hiring you, okay? Because they know that not only you can have, you know, the pros background, right? But you know, like they can just deal with any patient, right? In a hospital facility. Hospitals, it's some hospitals, they don't do a lot of fixed cases, right? So you might not do a lot of your whatever you learn in pros, right? I used to be like, you know, get like frustrated because MD Anderson, we do some fixed, we don't do a lot of fixed cases. It's very removable, right? Your fix, you get that in your pros program. In a cancer center, they don't do a lot of fixed. The patient needs to come back for scanning. You know, they might get every six months, a year to do a CT scan to make sure there's no recurrence of their cancer. So trying to remove that from their mouth, their cornea or titanium, it's gonna take a lot of time. And if they go, they might have a lot of scattering, right? But they're working on some studies right now, and I think they're gonna publish it soon. They're actually testing, right? If they're actually if there's a huge scattering from zirconia or titanium, that, you know, maybe if there's not, then maybe they can start doing more fixed cases, right? That's the goal. But yeah, I did some few cases, some fixed cases at MD Anderson, but not a lot. And then when you go to private practice, it's better, right? Because a lot of times, if there's a hospital that doesn't have a maxillofacial in their hospital, you can go in as a private office, right? And that's better than trying to get hired by the hospital, I think, right? Well, it depends. It depends what you like. If you like the business side, you may want to have a practice inside the hospital, and then you see all their patients, right? And plus other patients that come out. Or you can go in a private practice as well. But I think if you're gonna go in a private practice, you can do a lot of your pros cases. But if you want to bring maxillofacial, you need to get to know your hospitals and their head and neck and plastic surgeons. So you need to make friends with them. Any hospital nearby, make sure they know who you are and they can send your patients there. And I think, and that's what I told you, you don't have to just depend on your colleagues. Now you have MDs that will send you patients. And that makes a difference. You know, if you're a private practice, you can get patients from different sources.
Any other questions?
It was applying for pros.
Oh, I know I am, but
I was like,
we'll see.
yes. Go ahead.
So is implantology usually incorporated in each program?
Yes. So in 2016, as part of the quota, you have to place implants when you go to pros, right? Like I told you, some programs, so if you guys apply and you go for interview, ask them, right? How many implants does your residents place at the end? Or how do they get along? Or is it hard for them because there's perio, there's oral surgery? But implant is part of pros. It's incorporated. You have to place implant before you graduate from pros. Some places they'll let you do as many as you want. And that's the beauty of it. If you like surgery, some people don't like surgery. No, that's fine too.
And one more question is that, are they usually stipend programs or how?
That's a good question. So some program, they don't give you stipend. So I know the VA, they do. And I think MD, I think UCLA as well, right? If not mistaken, I think 2016 they started giving stipend to their residents, which is not bad, I think, because they used to give them only 20,000, which didn't cover anything. But most of them, you're going to be between 53 to 60,000 on average. Where they give you, some places they give you more, depends on the cost of living. I think San Francisco gives about 74, 80, I think. But it's more expensive to live there. But only a few places they give you stipend. The VA for sure, and I think UCLA. I'm not sure about other programs, but that's something you may want to consider if you when you apply.
If no one else has questions, I'll just end with one more question. Could you just tell us what your plans are for this year? Oh, connection.